Good day, everybody. Welcome to our second May month webinar. My name is Marlene Bagatto. I am an assistant professor in the School of Communication Sciences and Disorders and the National Center for Audiology at Western University. Welcome, everybody, and thank you for joining me today as I talk about something that I'm very passionate about and is my teaching and research area at the university, and that relates to pediatric audiology, in particular infant hearing health systems and how they can support babies to get the best start in life. Before we get started, I would like to acknowledge that Western University is located on the traditional lands of the Anishinaabeg, Haudenosaunee, Lenapehouk, and Chinookan nations on lands connected with the London Township and Sombra Treaties of 1796 and the Dish with One Spoon Covenant Wampum. It is on these traditional territories where this lecture was produced. This land continues to be home to diverse Indigenous peoples with whom I recognize as contemporary stewards of the land and vital contributors of our society. I am committed to learning the truth about the tragic and painful legacy of residential schools in Canada, the missing children, the families left behind, and the survivors of these institutions. Through my work with children and their families in audiology, I will continue to remind myself of the ongoing impacts of residential schools and acknowledge my positionality and privilege during my own work towards reconciliation. So here is a beautiful baby. This baby might have a hearing loss. This baby cannot tell you with words or actions that they have a hearing loss. And it is this particular aspect that I am very passionate about and am interested in sharing with you today why it's important for us to know at birth why we need to know the hearing status of a baby. 1 to 3 out of 1,000 babies are born with permanent hearing loss every year. In Canada, this relates to about 300 to over 1,000 new cases of newborn hearing loss every year in our country. This does not include late onset or progressive hearing losses that may occur after the baby is born. Knowing the status of a baby as early as possible assists the family with decisions for support. This support can be in the form of hearing aids and supporting the child to learn how to talk, but it can also support families who choose to have their child learn sign language, which is part of their identity within the deaf community. Programs known as early hearing detection and intervention are existing. They have existed for decades, and we know that they work. So I'm going to share with you today what's involved in these programs and why we need to ensure that they are available to all babies across Canada. So why do we need to know that a baby can hear early, or whether the baby can't hear early and how we will support their process through learning? By knowing something early about an infant, as you can see here in this picture, there's a lot of learning going on, a lot of developing going on. And this includes things such as language development, cognitive development, which facilitates psychosocial well-being, their behavioral characteristics, and ultimately academic and vocational success. Knowing if there is an issue that we can overcome with a baby early on, this will save us all resources with intense remediation that might be required. In particular, for language development, there is a critical period in which the brain is most absorptive to learning those speech sounds, and that critical period is from birth to age 2. So by knowing the child's hearing status and making recommendations that the family wishes to pursue to support that language development means that we can access and capitalize on that critical period for language learning. And this gives the baby the best start in life. So this is Archer. Archer is very young, a few weeks old, and he's wearing a hearing aid. So for the non-audiologists and speech language pathologists joining me today, this is possible. We have the technology, we have the protocols, we have the expertise as audiologists to identify Archer's hearing loss as early as a few weeks of life, and we can provide him with hearing aids that are safe and effective so that he can hear his mom's voice and he can develop the skills that he needs to talk to her. So often I hear the term hearing screening program. So I would like to just set the stage here that the hearing screening part of these programs is but one part, and it's the entrance. The screening alone is not diagnostic or therapeutic. In that sense, it does not tell us all we need to know about the child's hearing status, and it doesn't help support the child in getting access to spoken language or the American Sign Language supports that they might need. So this is the entrance into the program of hearing healthcare. So in that regard, I feel that terminology for infant hearing healthcare is important. Screening alone does not support infant hearing health. We also need mechanisms to confirm hearing status of the infant and offer the proper support services that are required and chosen by the family. The supports, as you saw with Archer, may include hearing aids or later cochlear implants and language development services that support spoken language or sign language. Unfortunately, many provinces and territories lack the necessary follow-up services, and some have no access to hearing screening at all for newborns. And I'll share the details of that shortly. Let's just go back to the screening component. So we have all learned a lot about screening tests during our time in the pandemic. And screening is rooted in very particular principles that were set out a long time ago by the World Health Organization. And that is the condition that we're trying to identify must be an important health problem. And I think I've established that we need to know the status of a baby's hearing so that we can provide the necessary supports so that they can develop appropriately and have the best start in life. There should be an accepted treatment, which I've just indicated for hearing loss. We must have the facilities for diagnosis and treatment available once the screening is complete. There should be a recognizable latent or early symptomatic stage, which again, we can recognize that through our testing. We have suitable tests for examination. It is acceptable to the infant population, which I'll share shortly. There must be a natural history of the condition that is adequately understood. And again, the literature indicates without exposure to spoken language, a child will not be able to develop their own spoken language skills. There should be an agreed upon policy on who to treat as patients. The cost should be economically balanced. I've already indicated that it saves money to spend money for infant hearing healthcare. And this case finding or our ability to identify children and provide infant hearing healthcare services should be a continuous process. So I strongly assert here that infant hearing healthcare services, when implemented properly and they begin by universal newborn hearing screening, check all of these boxes. So we do have the screening and all of the follow-up available to us if it is implemented appropriately within the provinces and territories. So rather than using the term hearing screening, the term in our industry is called early hearing loss detection and intervention, or this acronym, as I will refer to it, as an EDDI program. So these programs go beyond the population screening of newborn hearing and offer services to confirm the presence or absence of hearing loss and provide timely, equitable support services if permanent hearing loss is detected in the baby. This is critical in the lives of the deaf and hard of hearing community and children who have hearing loss to ensure optimized language, literacy, and social skills development to support success in life. So I'd like to move back to the part where I said not all provinces and territories in Canada have these complete EDDI programs. So this slide shows some work that I did with the Canadian Infant Hearing Task Force about 5 years ago, showing the status of these EDDI programs in Canada. So the red provinces are showing their status as having an incomplete or insufficient infant hearing health system, and the green provinces and territories have the necessary components to deliver comprehensive infant hearing health services. So this is an unfortunate situation that has been perpetuated for decades in Canada. And as part of the Canadian Infant Hearing Task Force, which I've been a part of and was the chair up until recently for about 6 years, we have been working to advocate and promote comprehensive EDDI programs in all Canadian provinces and territories. So this is a joint effort of the Canadian Academy of Audiology and the Speech, Language and Audiology Canada group. We continue to advocate for these services, and we feel that it should not matter where you were born and what your postal code is to have the best start in life through an infant hearing health system. So what is included in these EDDI programs? Well, the first is that universal screening of all newborns, regardless of whether they have a risk indicator that makes them more susceptible to hearing loss. That will only address or identify 50% of the population. Children who have no risk factors can also be born with hearing loss that's impactful to their development. So universal screening of all newborns is the entrance point of these EDDI programs. If the baby refers, then we need tools to identify whether or not the baby has permanent hearing loss, as in point 2. If the child was identified as having permanent hearing loss, then we provide evidence-based intervention and support services that includes technology with hearing devices and communication development through spoken or sign language. These are all based on informed decision-making and engaged parental choice. Throughout this process, and especially when the child is identified as having a hearing loss, the provision of family support is a key component of these programs. And in order to ensure that we're tracking and following all babies and demonstrating that the outcomes of these programs are suitable, we have a monitoring and measuring system within these programs through the use of a database and tracking system. So what is the target population? So it's really important for these programs which require resources to be clear about what the population is that we're thinking about here. And it is those children who have permanent hearing loss. So for the non-audiologists on the call, sensory neural hearing loss that is greater than a level of 25, as you see there, occurs in the cochlea where the hair cells are. So that's that snail-like purple thing on the right-hand side of the screen. So when someone has a hearing loss that can't be fixed with medication or surgery, this is a sensory neural hearing loss of a particular degree that we are identifying in babies. So 25 dB, that's even softer than a whisper. So mild hearing losses and all the way up to profound hearing losses are included in this target population. There's a condition called auditory neuropathy spectrum disorder that we also want to identify, and that has to do with the transmission of the sound from the cochlea to the brain, and we can identify that. And that can impact speech development if noted in a baby as well, and we can identify and support that. Also, there are some conditions where a hearing loss has a conductive situation where the outer ear might be not developed appropriately, or the ear canal is closed, and that condition will last for several years, months to years, until the child has surgery. So we would consider this a permanent situation, and we would want to keep those children and follow them within the EDI programs. So things like middle ear infections are not considered permanent within the target population of these EDI systems. So just again, from a resource and a medical perspective, the populations not targeted in these EDI programs are those children who have an ear infection that can be treated in the medical system. So in Ontario, that would be OHIP. Or so where they would get tubes and it would be resolved. So we just want to make sure that it is something that is going to last through that critical period and beyond, and we will be able to provide those supports and services because the permanency of their hearing loss will last a lifetime. Children with ear infections are well managed by the medical and surgical systems. So I am most familiar with Ontario's infant hearing program. It's the longest running EDI program in Canada. It's been around since 2001, and at Western University at the National Centre for Audiology, we have been involved with it since the beginning or before it started. So we've been lucky enough to have some influence on the protocols and development and implementation of the program. So just as an idea, each year since its implementation, the Ontario Infant Hearing Program has screened upwards of 97% of all Ontario babies born. This exceeds the internationally set target for universal newborn hearing screening, which is set at 90%. And each year, the program screens about approximately over 130,000 babies. And based on the prevalence estimates and what we see in our database, we identify approximately 450 infants with permanent hearing loss each year. Since it started, the Ontario program has screened over 2 million newborns. So this is the type of data we can gather if databases and tracking and monitoring are available within that system, and it helps supports renewal of the resources moving forward. So one of the audiologists have a lot of acronyms, right? So the one acronym that I showed you there was JCIH, and that's the Joint Committee on Infant Hearing. They have been around since the 70s, and they have been the group that has defined what type of performance guidelines and benchmarks we should strive for when we set up an EDI program. So what we're doing is not new. It's very evidence informed, and it's not experimental. So some of the EDI performance benchmarks by the Joint Committee are that we should strive to have 95% of newborns complete their hearing screening by 1 month corrected age. And those who do not pass, they should have their complete hearing test conducted by an audiologist no later than 3 months corrected age. And if those babies have confirmed permanent hearing loss, and families choose to have their child wear hearing aids, that should be provided within 1 month of the date of hearing loss identification. Some children might take a bit longer for a variety of reasons to be identified, and in which case we want to ensure that intervention is initiated no later than 6 months of age, and this would include any technology and language supports as chosen by the family. So these are very specific, and if you're new to this, I would like to impress upon you that we do have evidence, and it continues to grow for all of these EDI programs and its components. So the Joint Committee, there's a group in the US that have looked at outcomes of children who have hearing loss and wear hearing aids. The National Center for Hearing Assessment and Management based in the US has a lot of great resources to develop and implement these programs. In Australia, they've also looked at outcomes longitudinally of children who have hearing loss and wear hearing aids. My laboratory at Western continues to develop develop protocols that support these systems from a policy level as well as a clinical level. And again, the Infant Hearing Task Force remains active. It's very important for us to ensure that we consider the family in all of this. So there is, in addition to what seems to be the more technical pieces of what we're doing with babies, is we want to ensure that it's a family-centered early intervention program and that qualified providers are providing these services. So there is a technical component that does require expertise and particular training beyond what an audiologist might learn in the training program, for example. So the service providers who are involved with EDI programs include those personnel who are trained to deliver the hearing screening itself at the newborn stage. So this can be a nurse who works in the hospital or a communication disorders assistant. And they are often overseen by an audiologist who has the knowledge in the procedure, but the equipment being used is quite automated. And the nurses and the communication disorders assistants have the necessary capabilities, and we will train them to work with babies to settle them and conduct the screening. The infant hearing assessment and the provision of hearing aids is then reserved for the audiologists who are specially trained to provide those services to newborns and infants and young children who have hearing loss. So and there's not a lot of audiologists, and the pediatric audiology world is even smaller. So we are trained to do the infant hearing assessment and provide hearing aids and cochlear implants. Family support workers, an important part of this program, are typically social workers with experience working with infants who have been identified with permanent hearing loss. And again, they're coached along by the audiologists who have the content expertise in infant hearing loss. And then the language development services are provided by speech language pathologists if the family chooses a spoken language route, or ASL consultants, American Sign Language consultants, for families who choose a sign language route. So you can see this is a very big team approach, which requires that systematic setup so that families are rooted through the process and everyone is connected to ensure this interprofessional collaboration where the family is the center of the work. So for all of the EDI components, we and the Joint Committee recommend having evidence-based mandatory protocols, using uniform equipment across each stage of the program, have mandatory standardized training for service providers, and include outcome measurement, again, to support our continuous quality improvement of the program and demonstrate and continue to demonstrate that what we are doing works. So this is just a snapshot. I don't want to make it sound like it's very simple, but it is a comprehensive program that needs to be well thought out and implemented. And again, we've managed to do this in Ontario for over 20 years. This is a snapshot of the EDI service pathway. So you'll see here that it starts with the universal newborn hearing screening aspect. And then if they pass, and they don't have a risk factor, they can be discharged. And if they do have a risk factor, we have an audiologic surveillance program to ensure that if a hearing loss does develop after the newborn period, we're able to identify that as early as possible. We'll then do some other screening levels if they refer to get them to audiology assessment. And if they pass, and they can be discharged again. And if there is a risk factor and they're normal, we will follow them again. And if they do have a hearing loss, then within the system of services, we provide those services to families. And we also initiate the necessary medical referrals for any further scans that are required to ensure that we have a full understanding of the etiology or the reason for the hearing loss. So within each of those components, again, we need to have a protocol. So this, for those of you who are interested to see what those are, these are QR codes to my lab's website. This is just a separate, same QR code, but just a separate list to show you that these are the separate protocols for each stage of the program, which goes from screening to hearing assessment. Again, lots of nice acronyms there for you. The amplification, language development, and a protocol that we developed pretty quickly during COVID when a lot of babies were missed during the initial lockdowns. So where have we come from? This is an excellent picture that I love to share of my one person who has allowed pediatric audiology to become what it is today. So on the left-hand side is Dr. Richard Seawald, who is screening a baby in the 1960s. And he tells me his colleague on the right is watching as he blasts a 90 dB narrowband signal into that baby's ear in the bassinet. And his colleague looks to see whether there is some sort of response from the baby. So I can assure you that this is not how we're doing it today. And I think Dr. Seawald would say that maybe it wasn't as clear to him when the babies were responding or not. So also, just from a technical standpoint, 90 decibels is quite loud. So even if the baby did respond or not, we're talking about very soft levels that we want to check to see whether the baby has good hearing or not. So most babies would probably respond at that loud level. So we just want to make sure that we're testing the target population appropriately. So again, we've come a long way from that. And thank you, Dr. Seawald, for getting us started on the right path. Another test, so this speaks to the softness of the signal. Again, looking for a behavioral response from a newborn is not very clear cut for us. So what we then want to move towards, and what we have for decades, is testing the baby while they're sleeping, simply placing an ear tip in their ear and delivering soft sounds to their ear and measuring sounds that are naturally coming from their healthy hair cells in their cochlea. So we can measure these, and this is the screening component that you're seeing, and that allows us to determine within a few hours of birth if the baby needs to go for further testing or not. So let's talk a little bit more about the screening component, because it's one of the more complicated sections. So it's a very simple test. This part will not be on the exam, I promise. But this shows you the complexity and the importance of a very well-trained and knowledgeable and skilled hearing screener, where they have to identify whether the baby has a risk factor according to the protocol, decide which type of screening technology to use, execute the screening appropriately so we're not getting too many babies that pass and too many babies that refer. So we want to identify or get the children who need further testing, and we don't want to miss any babies. So there's an important balance here with the technology and the protocols and the resources provided. So in terms of the risk factor, this is something that the hearing screener will check for in the baby through the medical records or by talking with the families, and they're compared to a particular set of risk indicators that have been identified in our protocols based on the evidence and the likelihood that that baby would have an increased likelihood of having permanent hearing loss either now or in the childhood period. Okay, so we have to be careful about which risk indicators we are choosing, because we want to not over-resource the situation by following every child that might develop hearing loss later. So no risk is something that the baby might be assigned, so they wouldn't have any of those specific risk indicators, and that means they're less likely to have hearing loss. And if they pass the universal screening, we would discharge them. If they do have a risk factor and they pass, they have a high likelihood of developing permanent hearing loss compared to their baby friend who has no risk. So we want to make sure we document that correctly and then follow that child for a surveillance appointment later on at particular intervals in their early childhood. This ensures we are able to identify the permanent hearing loss as soon as it develops, if it does. So specifically, the equipment that we use is called an automated distortion product otoacoustic emission. So again, that's where a signal is delivered. It's very soft into the ear. The baby is sleeping and should be sleeping so that the probe in the ear can record the very soft sounds that are emitted from the ear, which indicates a healthy cochlea or healthy hair cells functioning. The other type of hearing screening technology that we will use is automated auditory brainstem response. So in addition to putting the tip in the ear, we will put electrodes on the baby's head and around their ears, deliver a soft clicking sound in the ear around 35 decibels, and record the baby's brain waves in response to that sound while they're sleeping. So both are done while the baby is sleeping. So this results in the unit itself saying the baby has passed or not passed. And then if they don't pass, that simply means to the family that the baby needs further testing by an audiologist, where they will go to the audiologist and have a more fulsome audiology assessment in, at the 6 to 8 week age point. So you've seen a bit of an evolution in the universal screening portion from a narrowband sound speaker to a little bell to what we would call electrophysiological hearing screening. So what we have had in Ontario since 2019 is universal screening of all babies for what we call hearing loss risk factors. So these include genetic mutations, as what we know are genetic mutations that are associated with permanent hearing loss, as well as something called congenital cytomegalovirus. So CCMV, as you see there, is a virus from the herpes family that's commonly found in the population. If a mom has it, it could be dormant and not showing any signs in her, but a baby could be born with it, and that could cause many developmental impacts to the child. If we know about the viral load of CMV at birth, then we can, or the group, the team of an infectious disease physician, for example, will decide with the family if an antiviral is necessary. So being able to identify early and offer that antiviral within the first 3 weeks of life means that the impact of the CMV virus can be mitigated, and the impacts, one of which is hearing loss, could be prevented. So cytomegalovirus is the leading cause of non-genetic hearing loss in newborns. So these programs have and should have an interest in universally screening for CMV at birth, all babies. So this is the only kind of program worldwide where we are using the blood spot, which is a standard of care when babies are born in I would think every province in Canada and territory in Canada. But adding the hearing loss risk factors to the blood spot that's being drawn is what's unique to Ontario. So, and this has been going on since 2019. Because of the importance of knowing whether or not a baby has cytomegalovirus, our Infant Hearing Task Force collaborated with CMV Canada to write a position statement on this very topic. So again, there is an inequity here in our healthcare system where some babies in Canada do not have access to CMV screening at birth. It's not offered universally anywhere other than Ontario and more recently Saskatchewan, I believe. So this position statement was provided in 2020. So if anyone is interested in advocating within their region, there are resources that you can use to impress upon the policymakers the importance of including universal screening for CMV. So the goal of this blood spot risk factor screen is to improve the effectiveness of having the hearing screener look at a list of risk factors. So that's effective, but this one is quite impactful because the parent or the medical chart wouldn't have this information. The blood spot is the best way to do that. So this will allow for earlier and more accurate identification of infants with specific risk factors. If they have a positive result on the blood spot, but they pass their electrophysiologic, their ear tip hearing screening, we will follow them and we will surveil them because there's a likelihood that they could develop hearing loss later, especially with the genetics and the CMV. Okay. For more information, the blood spot, again, Newborn Screening Ontario has been around for many, many decades, and the Ontario Infant Hearing Program collaborated with Newborn Screening Ontario for this work that we've been doing since 2019, but it takes a few years to get going, as I'm sure you can imagine. So that's the quick part of the screening portion. I will add that the audiologic assessment portion conducted by a skilled pediatric audiologist takes the form of what you see on the left, which is a diagnostic auditory brainstem response. You see the electrodes there on the baby. The baby is asleep in the clinic. They're about 6 to 8 weeks of age, ideally at their first test. And through this assessment, the audiologist is able to determine in each ear the degree and type, so sensory, neural, or conductive, as you learned earlier, of hearing loss in each ear. So that's important to know across multiple different pitches of sound, because we use that information then to fit the hearing aids if that's what the family chooses. But the goal of this is to identify, is the target hearing loss present, and can we further define that to support our intervention recommendations? On the right, you're seeing a little bit of an older baby. So when a baby is around 6 or 7 months, we are going to continue to check their hearing, make sure it's not changing, and adjust things as we go. They're moving targets, these little ones. And this is a conditioned behavioral audiometry paradigm where the child hears a sound and is trained that the toy will light up, which is reinforcing for them when they turn their head to the sound when they hear it. So the audiologist, again, is a keen observer of the baby's head turns and knows when to manipulate the sounds louder or softer in which ear, and for the frequencies that are necessary. So it gets roughly the same result as the sleeping ABR test, but it's more compatible with an older baby who's not going to sleep very long for us. So when the child is identified with a permanent hearing loss, you may consider that this is big sensitive news for the family, especially if they themselves don't have a hearing loss. So it could be the first time they've ever met somebody with a hearing loss, and they're learning from us that it has implications for the child's development. So the family support worker is key in having the family understand what the hearing loss is, helps the family work through the system with us, any financial applications that may be required to obtain hearing aids. They help the family understand what hearing loss means again, and how language can be supported and what the different options are for language supports. And they will also facilitate parent-parent connections. These are very powerful and help families work through the process and what they're learning as their baby is growing. So language development, as I mentioned, the families are supported in choosing whether they would like to pursue spoken language or sign language for their child. We, again, want to follow the recommendations from the Joint Committee on Infant Hearing as much as possible and try to have these services implemented for the child no later than 6 months of age. This, again, supports that critical period for language development, and we want to ensure that we're maximizing that really active time in the child's brain where they're making a lot of connections and they're absorbing everything they can. We aim to try to provide services as close to home as possible. This is specific to Ontario. The Preschool Speech and Language Program provides spoken language services, and Silent Voice provides ASL support for families who choose American Sign Language for their child. For families who choose spoken language development for their child, it is critical and imperative that the child have hearing aids and wear them consistently. Without that consistent access to sound, the spoken language has no chance of developing. So this is why it's important to truly identify the detail of the hearing loss, and we can use that information to fit the hearing aids accurately. So we do have these evidence-based protocols that are followed to ensure that the child is getting optimal access to sound with their hearing aids, and we can fit them with hearing aids as early as 3 months of age. With the timing of all of the other items, they're often, it's a little closer to 6 months of age, but again, that still aligns with the Joint Committee on Infant Hearing. And as a note, because it is Western, I will say the procedures that we use today and that are used worldwide that have been around since the 80s were developed here at Western University, again, led by Dr. Richard Seawald, and it was the world's first pediatric hearing aid prescriptive formula. So we are very proud of that. We continue with that legacy to this day here at the National Center for Audiology. So again, I've said that hearing aid fitting to infants provides access to speech to support spoken language development. And this is a picture of a child. There's very nicely developed physical outward appearance of the hearing aids, as well as the technology inside to support our ability to achieve what we need to for our children. Again, there's differences from how we would do that with adults versus infants and young children, because children have their hearing loss from birth. They don't have any context of language like an adult who has lost their hearing at age 60 or 70, for example, and they have already learned language. So a lovely quote from Dr. Seawald. You can tell I'm a fan of Dr. Seawald's, but many years ago at a conference, he said, whether it be an ear trumpet, an analog, or high-end digital instrument, it's the audiologist who is ultimately responsible for the appropriateness and accuracy of the hearing instrument fitting. This is because the long-term implications of the fitting decisions we make are simply too important. So going back to the World Health Organization principles for screening, it is this that allows us to ensure and feel good about the fact that when we screen babies, we do have the appropriate ways to support children if families would like the child to learn spoken language. So we have done this over the years in many ways, and because of the way it works with children versus adults differently, a lot of the hearing aid test equipment that we use in audiology and the hearing aids themselves are designed with adults in mind. So we have worked with all of the industry partners to ensure that the processes that we use and need to use for infants to fit hearing aids are suitable for that population. So the infants have different considerations. The person applying the hearing aid is the parent. or a caregiver, an educator. So we need to ensure that all of that is messaged to them appropriately and they are trained and it's as easy as possible. And also the connection between the need to wear the hearing aids all day long or as much as possible throughout the day, especially in the education setting, is critical to the child's development. This is a snapshot again of what happens during the amplification process. It's not simply here's your hearing aids, but we are constantly working with the team, the ear, nose, and throat physician to make sure we have a CT or an MRI approval for the hearing aids. We talk to the family about what type of hearing aid, the importance of wearing it, how to use the hearing aid, how to troubleshoot it, what to do if it starts whistling, ensuring that it's comfortable on the baby's ear. So this is what that pediatric audiologist is going to do and see that family pretty regularly during that first year of hearing aid use. So this was Archer's very first hearing aid fitting, and his family is going to go back several times to see the audiologist for adjustments. His ear is going to keep growing. So we're going to keep making that ear mold, that clear bit that's in his ear. We're going to keep making that again because his ear is going to keep changing, and we're going to adjust the hearing aid to make sure the sound levels remain appropriate as he grows. So that's what's going to happen as we continue seeing the child and family, and we're going to retest his hearing. So any changes in his hearing, because sometimes the hearing loss gets worse over time, we want to adjust the output or the sound coming out of the hearing aids to make sure that it's giving the child the most optimal access to speech. So the details of what's involved in there, for those of you who are interested in reading, light reading over the long weekend, there's probably 100-page protocol to describe the details for the audiologist. This is the Ontario protocol to describe exactly the necessary components of how to provide hearing aids and fit them to infants and young children. And again, this is used and shared by other places who have infant hearing programs that are comprehensive. So it's established and it can be modified for different clinical contexts. Language services are about gathering and sharing information about the child and then having the family make an informed decision whether they would like spoken or sign language. A child who is, wearing hearing aids can also learn sign language as well. So this is still an option. We're just presenting them this way, as there's different ways to communicate, and American Sign Language is a viable language that has its own grammatical structure and is a suitable way to communicate. So in that regard, these language services are supported for both. And either one that's used, a communication plan is developed among the team. And then we will, as the audiologist and the language support person, will implement services and measure language development progress and hold team meetings every 6 months. So again, simply providing hearing aids is not on its own the only thing that is necessary to support the child's language development. It needs to be monitored, some exercises depending on where the child is developing. And maybe it's just watchful waiting and checking in every 6 months, because the hearing aids and the language-rich environment that the family is providing is good for that child. But we want to, within the context of these EDI programs, make sure that we monitor how the child is doing. So I've given you a snapshot, hopefully, of the extensive components of infant hearing healthcare. This sense of hearing is critical for the development of children. We have learned to call it generally an invisible disability. Whether or not that's the appropriate terminology, I again assert that you cannot tell that the baby has a hearing loss when they're born. Therefore, we need to do screening of all babies and have the necessary components moving forward should the baby need further assessment and support to learn how to communicate. So you can see there's a lot that goes on with the development of the child, whether it be spoken or sign, technology, not technology. Having access to the information is what helps the child grow. So having access to the services that we know to work and have been working in provinces like Ontario for over 20 years is what is needed in every province and territory in Canada. So it can start with a simple test in the ear when the child is born, and can grow from there if the services are implemented and available. So in summary, 7 out of 13 provinces and territories do not have these comprehensive early hearing detection intervention programs. We have growing evidence to support and guide the implementation and sustainability of these programs, and they save society money overall. They save families individual resources from trying to figure out what is the status of my child's hearing, what support is available, where can I find it, who is the best person to see. EDI programs offer these systematic hearing health services for infants. What we are doing is not experimental. It is here. It has been here. It continues to grow. And I'm very proud to say that Western and those who have worked here many decades before I have laid the foundation for these programs. And I'm pleased that we are able to continue that. And I hope that regardless of whether you are connected with audiology or speech pathology, joining me today, or you're a parent, or a new parent, or a soon-to-be parent, I hope that you learned something important today about infant hearing and that it can be addressed and there are services available. So thank you, and I'm happy to address any questions you might have.
Thank you so much, Marlene, for that wonderful and informative webinar. You should all be able to see the chat function where you can send in your questions, and then Marlene can answer some of them. As well, if you would like to return to some of the slides or information in this webinar, we will be posting it on the Western Faculty of Health Sciences YouTube channel, which I'm sending in the chat now. Thank you again.
Okay. Quiet group today. All right, well, thank you so much. And my email was shared there. I'm happy. Oh, there's a question. Is there a plan in place to address the inequities in other provinces and territories? So as I mentioned, the Canadian Infant Hearing Task Force is alive and well. They are active. You may see a few more things from them in the coming months. And I would add that healthcare in general is administered by the provinces and territories individually. So it's not unless there is a national mandate, which we don't have, to implement these infant hearing health systems, it is up to the individual province and territory to advocate to have those systems. So this is a policy making situation. So we're lucky that Ontario, British Columbia, Alberta, Nova Scotia have these programs that we can rely on to support other provinces who don't have them. But at the end of the day, the inequities need to be addressed at the provincial and territorial level. It would help if the federal government said, we need this across the country, and we want you to use some of your healthcare money that we give you for your for this in your healthcare budget, but currently that's not the case. So the Infant Hearing Task Force is well aware of this, and we have representation from across the country. So we are working from a national, but also a provincial and territorial level as well. So I'm doing whatever I can to help as a sort of an Ontario-based person, but someone who has knowledge and feels passionate that this inequity needs to go away. So thanks for your question. Thanks, Julia. Okay. Great. Any other questions? Okay. We're probably okay. All right, well, thank you so much.